Hi, my name is Paige Weaver, and today I'm presenting on Dysphagia Screening Quality Improvement Project for Nursing 405 for fall of 2021. Dysphagia is a very common complication in the acute phase of stroke. So approximately 30 to 60% of patients are going to have some type of sign or symptom of dysphagia during this time. Dysphagia is an independent predictor of poor outcomes. You have higher mortality rates and increased length of stay, which leads to increased financial cost during the hospitalization. Patients who have signs and symptoms of dysphagia are also 3 times more likely to develop aspiration pneumonia. And once this occurs, you have a higher likelihood of increasing your mortality rate, and about 1/3 of all stroke patients' deaths are associated with aspiration pneumonia. So our goal is we never want to cause harm for any of our patients. So if we can stop these patients from developing aspiration pneumonia by identifying these signs early in their hospitalization, we can help to reduce aspiration pneumonia, reduce their length of stay, and affect their mortality rate. So once the screening's been performed, if these patients have severe signs, we can implement interventions such as getting a speech consult, keeping the patient NPO until appropriate swallowing screening has been performed by a speech language pathologist. And after reviewing the information at Lake Charles Memorial, we've determined that about 34% of these patients are not receiving this dysphagia screening during their stay, and specifically in the emergency department. Whenever we took our project and wanted to break down and get all of our information so we could identify the areas that we believe are going to have the best outcomes for our patients, there's a lot of different things that cause the screening to not be performed in the emergency room. COVID has changed a lot of things for us within the hospital, and I know nationwide, it's affected our staffing. We have a very high turnover rate right now, just related to people leaving to go travel to do travel nursing. We also have high travel nursing right now as well. Travel nursing, whenever they come in, they only get 1 day of orientation. It's not the same length or in-depth that nurses who are hired in the hospital get. So that's changed. It's also taken away our face-to-face education with orientation. So prior to COVID, I would meet with every nurse who was hired through the hospital, and we'd able to talk about the things that we needed from the stroke program and the things that are going to keep our patients safe and best practice. But after that, we've gone away and we've primarily gone to computer orientation, which doesn't have the same lasting effects that in-person does. Some of it's also the inability to identify atypical stroke symptoms. So we're pretty good at identifying those patients who come in with arm weakness, facial droop, but the subtle signs of stroke, such as dizziness or vision loss, gait disturbance, those tend to be missed due to either lack of awareness that those are stroke symptoms, decreased education. They're not getting the entire orientation process whenever they're hired. Staffing is also an issue, just because short staffing has been an issue nationwide, hence why we have so many travelers. But just making sure that we are adequately staffed to perform all the necessary screenings or interventions that we should be doing within the emergency department. We also have a difficult EMR. It isn't bedside nurse friendly, so sometimes the orders can be difficult to read. The doctors don't always use the order sets, and we're not getting a good handoff between the ER to the floor. Once the team identified all of these problems, we came back and tried to decide which were going to be the most impactful on the things, on what we could make changes for. So a new EMR is an amazing idea, but to say that we could implement this in 6 weeks, have the funding for it, or really overhaul our current EMR and make these large changes, it wasn't something that we could do in a short amount of time. So we decided, after looking at multi-level staffing concerns, that's not necessarily something as a stroke coordinator that I can change. Not necessarily, I can always recruit nurses, but to say that I can increase the nurses staffing part in the emergency room or get more travelers. That's not necessarily something that's within my capability, but knowledge deficit is something that I could handle. So revamping education or getting more education out there, reminding doctors to use the order sets, make sure that the order sets are appropriate so they feel comfortable using them, and also get a better handoff between the ER and the floor. So whether that's talking to IT or talking to the nurses and just helping that SBAR handoff, those were the things that we identified that we could have the most impact if we changed. After doing our fishbone, we wanted to break down the process and kind of see from the time that the patient arrives to the time that they're screened or we identify that they're having a stroke. What's the process? Is it the nurse the one who's identifying the stroke patient, hopefully? Once the provider comes, are they using the appropriate order set? So the nurse, if the doctor is thinking that it's a atypical stroke, they're using the order sets to also clue in the nurse that this is our plan. And then also that the nurses have the ability to screen these patients. So if they feel that this is a new neurological change that could be a stroke, do they feel comfortable doing this assessment without a physician's order? And also to make sure that it's done prior to the patient receiving anything by mouth and that it's documented appropriately. So our aim for our project is to improve dysphagia screen compliance by the ED nurses to achieve and maintain a goal of greater than 90%. We'd like to continue auditing until this has been maintained for 6 months. And hopefully we'll see changes by improving the compliance of the dysphagia screen. We'll see changes, improvement in the length of stay for patients, decreased mortality rate, and hopefully have improved outcomes. So our measures, the 3 different types of measures that we're looking at, our outcome measure, we're looking to see that the number of patients who develop stroke patients who develop aspiration pneumonia decreases. We also want to see that our hospital length of stay for stroke patient decreases and that our mortality rates as well are going to come down. Our process measures, so this is going to be where we're actually looking for the compliance with the dysphagia screen within the emergency department and the use of the order sets by the doctors. And then our balancing measure, we want to make sure that we're not putting too much undue burden onto the emergency staff and make sure that they're not having really long increased length of stay due to us implementing this process in the emergency department. We're going to compare the outcome and the balancing measures to the last 6 months of data to see where our medians lie and to see what our goals are. Our planned intervention, so we want to increase education that's provided. And so this is across the board, but it's really important that we're going back to face-to-face orientation on new hires. So we started January, the second week of November, we went back to face-to-face orientation. So they are getting this information right off the bat. They're also getting PowerPoint education as well with voiceovers where we go step by step on how to perform the screen. Also doing twice-a-year education with the emergency room staff. So it is required as a primary stroke center that the ER gets twice-a-year education on alteplase, but by adding in the dysphagia and the importance of completing this screen during that same education, they'll be getting it multiple times to help reinforce this information. And then reminding the physicians the importance of using the order set, because the nurses are going to go off of those orders. And if they're thinking stroke early in the process, to make sure that we're capturing all the necessary orders on these patients. We also want to improve handoff between the floor and the emergency department. So work with IT on changing the SBAR for the floor nurses to ask if the patients had a dysphagia screen in the emergency department, did they pass or fail? And then also just doing education with the floor so they know that they can ask this for stroke patients. The majority of our stroke patients are going to be seen on 5 tower. And so if we can really hone in on 5 tower and say, you have this ability to ask the ER nurses, has this been completed? It should have been completed downstairs. Can we please complete it before it goes upstairs? The screening is not very in-depth. It takes less than 5 minutes to perform. So it should be something that they can have done prior to the patient going upstairs. And then a really important part is giving feedback to the nurses when the screening wasn't performed. So sometimes those atypical patients that they weren't necessarily thinking were strokes in the beginning end up being coded out as stroke or have a positive MRI. And so following up to make sure that they know that these are some of the atypical signs we should be looking for, and also just refreshing on this was a stroke, this is part of the order set, and these orders weren't followed. So proposal timeline, the goal is by January 1st, education is going to be completed. So that's with the emergency room. We've gone back to face-to-face orientation. We've completed education for the floor, so they understand that this is something that we should be asking for. Revamp the orientation education for dysphagia screening. All the nurses who are hired get this orientation for dysphagia now, and just to make sure that it's up to date, and that it's ready in our computer-based program, making sure that we're doing the feedbacks and then creating the form and handing it out by January 1st, making sure IT is creating reports that we need to monitor, and then also getting a baseline data from the last 6 months so we can see where we're starting and where we need to go. So we did a run chart. This is the baseline data for our process measure. So this is completion compliance for the dysphagia screen. It just kind of gives us from January of 2021, kind of shows where we were, how we've gone throughout the year, what our median is, and what our target goal is. So data collection, who, how, all those things. Who's going to do it? Who's going to follow up on it? How are we going to get this data so we can get it to the bedside? For the outcome measure, it's going to be based a lot off of IT creating reports on stroke patients' length of stay, the stroke mortality rates, and then also stroke patients who develop aspiration pneumonia. Those are going to be automatic reports, so you can go in and just type the month that you need the report for, and it'll propagate it. And then the process measure is going to be manually abstracted, and so that's where you're going in for all patients who are stroke admits, as well as patients who are final coded out as strokes. Go into each and every one of those charts to make sure that we have a dysphagia screen completed, that it was documented appropriately, and if it wasn't, follow up with the nurse. And then another part of the process measure is IT to create a report that says if all stroke patients, the order set's been used, it'll flag the ones that it hasn't for the admitting diagnosis. And then the balancing measure, we're going to have another IT report created so we can see the stroke patient's ED length of stay to make sure that we're not extending that length of stay out too much. That'll be the same. It'll be a automatic report where you can just enter in the dates and pull it up. The data will be combined, and we're going to break it down and present in a chart format, kind of have the numerators and denominators so we can see how many patients we're seeing and how many's been completed and not. And then closing the loop, so bringing it all back around, making sure that the feedback to the staff whenever they haven't met the performance measures. So this really puts a personal touch. So you can review the chart with the nurse, you can tell them the things that were missing, possibly review signs or symptoms of stroke that maybe they didn't think were part of a neurological assessment and that should have clued us in. So that's really gonna help staff know the importance and what we're looking for. And then once the data has been collected, we're going to present it to all departments involved. So the ER specifically, but also the floor, 5 tower. It's going to be presented in the stroke committee, also in the ED committee, patient safety and quality committee. And then through these committees, it will be escalated up through the med exec committee, which is the physicians, and then to the board of directors. So we can show them the things that we're working on and our goals to meet these improvements. Just helps to let everybody know where we're at, where we're starting from, and what our goals are, helps transparency so we know what we're working for. And then also by collecting the data, looking at it, we're able to identify maybe some of the things that we've implemented aren't working, or maybe we need to tweak certain things. And so by doing this monthly, we'll be able to reassess and possibly tweak some things or make some other interventions so in order for us to meet our goals. So it's not just it's done and we're going to look at the data, but by doing it monthly and breaking it down and then reporting it to everybody, we can actually make changes to improve if we're not meeting that goal.